All right. So we're going to move along and start talking about management of patients with hematologic neoplasms. And so in this particular PowerPoint, I'm actually going to split this one in two as well. So I'll do leukemia first, and then I'll probably do the polycythemia vera separately because I don't want the audio to get to be too long. So key things with leukemia, we will talk about it in general at the very end. So we'll just be talking about cancer, we'll be talking about leukemia and what is the best way to treat it. However, we will describe it in how it presents, and I would like you to be familiar with which type of leukemia is most common in young kids versus which one is more common in older people. And then we'll, I guess, describe some of the differences between these conditions. But in terms of nursing as a whole, we will basically describe it as leukemia. What are the treatments? And pretty much the treatments will be the same. It's either doing some type of transplant, whether it's bone marrow transplantation, whether or not you're doing chemo or you're doing radiation, whatever. All of that will be similar. And there is another PowerPoint on cancer that will kind of touch on some of the same concepts as well. So we're looking specifically at hematopoietic malignancies, and that word hematopoietic has to do with blood cell production. So we are looking at all the different components that have to do with blood cell production, and you know that there's different types of cells basically that are involved. So for the hematopoietic malignancy, they can originate in the hematopoietic stem cells, they can originate in the myeloid or the lymphoid stem cells. So anything having to do with myeloid, you're thinking bone marrow. Anything with the lymphoid tissue, you're thinking lymphoid tissue right off the bat. And remember that your stem cells essentially are those cells that we came across already under immunity, I think it was, and we said that they had the potential to basically become anything, right? So we had touched on that already. So lymphomas are neoplasms of lymphoid tissue. So here, that third bullet is talking about the fact that there are what are known as clonal stem cell disorders, and they happen when the control mechanism fails and the indolent clone may evolve to more aggressive clone cells. So the key word here is that you have a type of stem cell, which is known as a clonal stem cell, and it basically is indolent. So it doesn't do anything to you, right? So it has a potential to become a bad cell in your body, but nothing happens to it initially. So things go bad at some point, not 100% sure what happens, but something triggers it, and then this indolent, very quiet clone may evolve to become more aggressive, and then it can actually hurt you. So clonal stem cell is a type of clone cell. You have this cell that has the potential to be bad, but your body basically protects you from it and nothing happens, right? But later on, the body can't, and then it can actually become aggressive and it can actually do some damage to you. So the word indolent by definition just means something that's kind of lethargic, or it's like a neoplasm. It's quiet, it's not doing anything, it's not bothering anybody. So maybe that's something that the doctors will be watching just to see if they evolve. And I think it's something that maybe if you have a history of cancer in your family, that's one thing that they may be paying particular attention to. But remember, there are many things that can predispose you to becoming sick. We've talked about stress a lot. Maybe you're getting your environment that you're in. In particular, when we're talking about cancer, those things all come into play as well. I've known, not in my family, but I've heard of not family members, I've heard of friends where there was no history of cancer whatsoever, but then like somebody went through a really traumatic event where there was a lot of stress. It could even be that maybe they had a child and then the child, was using drugs or something crazy like that, or they had a husband and the husband maybe came from war, and then just dealing with all of that, the stress of that sometimes the family member would end up getting cancer, and everybody would be shocked and be bewildered as to how come this person is all of a sudden sick. So anyway, you have these defense mechanisms in your body that try to protect you, and then sometimes they're overwhelmed just because of things that are happening in your life. So you always want to keep that in mind as well. All right, so for the hematopoietic malignancy, so malignancy is mal, means bad. Here, what you're going to see is unregulated proliferation of leukocytes. So we're talking about leukemia, so we're specifically focusing on leukocytes. And the key word is definitely unregulated proliferation. Unregulated proliferation. When it comes to cancer, it's always about proliferation. So you're always getting too much of a particular cell, and it's like, let's say in polycythemia vera, for instance, you're getting a lot of red blood cells, but unfortunately they're not the good types of red blood cells, so they don't do anything for your body. So when it comes to cancer, just always think of the word proliferation. You're getting a lot of something, but unfortunately it's not the good something. And then on top of that, they die off a lot. So you're getting a lot of them, and then they're dying off. You're getting a lot of them, they're dying off, and they're not helping you at all in terms of your normal homeostatic mechanisms. Like all of that just goes out the window. So when we're looking at leukemia here, we're looking at unregulated proliferation of leukocytes. So it can be acute or it can be chronic. So there are several different types of leukemia. So you can have acute myeloid leukemia, you can have chronic myeloid leukemia, you can have acute lymphocytic leukemia, you can also have chronic lymphocytic leukemia. So once again, we've already mentioned that if we're talking about myeloid, we're specifically focusing on the bone marrow. Your pathophysiology is pretty straightforward, right? So you're getting this malignant transformation of stem cells that happens. You're getting abnormal proliferation of a type of leukocyte. You're shutting down the normal bone marrow production of other cells. You may end up with things like anemia, thrombocytopenia, and leukopenia of unaffected WBCs. You may get death from infection or from hemorrhage. So depending on the type of leukemia, obviously, any of this is a possibility for to happen. So unfortunately, if it's the bone marrow is the one that is the main culprit, in order to treat the bone marrow, sometimes they'll give you immunosuppressants. So you're trying to treat the fact that maybe your bone marrow is hyperactive, but then you're giving you immunosuppressants to suppress the bone marrow, but then you're thinking of all the things that your bone marrow is supposed to do for you anyway. So then your bone marrow is not functioning properly. So usually the end result may be that you may just need to get a bone marrow transplant. Otherwise, this situation is really not going to work, because then the bone marrow is not going to be working properly. So just know that there's really a whole bunch of different things that can happen here, and the patient can end up with a very specific type of anemia. A lot of different things can cause cancer, and so some things we've talked about already in terms of environment. I'll mention a lot more of these factors in the other slide that is called cancer, because there's pictures in there of all the possible things that can cause cancer. But really, they're doing studies and making correlations. So some of the things include things like ionizing radiation. They're talking about the fact that maybe genetic factors are implicated as well. So now we're specifically talking about leukemia, and these are some of the things that they're saying are causative agents for leukemia. But when we're talking about cancer in general, quite honestly, things like radiation and genetic factors, viral factors, exposure, anti-neoplasm drugs, those are pretty much true for a lot of different types of cancers as well. And especially like for genetic factors, like we'll talk about breast cancer, and then we'll get into the BRCA1 and BRCA2 genes. Those have been implicated there, right? But right now we're under leukemia. So these are some of the things that they're highlighting for leukemia. So things like ionizing radiation, genetic factors, they mentioned Down syndrome. They're saying that people that have that extra chromosome 21, right? That these types of people are more likely to develop acute lymphocytic leukemia, or that they're also more predisposed to also get acute myeloid leukemia. All right, so that's something you'd want to factor in when you're doing your assessment as well. So any type of viral factors, exposure to radiation, for instance, I don't know, just any weird, I don't know, herbs in the environment. Any of those things could be a factor as well. Anti-neoplasm drugs for sure, like they're treating you for the one type of cancer, but then you become more susceptible to getting another different types of cancer, all because of just the suppression of your immune system that's also going with that when you're on these medications. Here we have the different types of leukemia again. So acute leukemia, abnormal growth of immature cells called blasts. So these are a type of white blood cells. And for chronic leukemia, so key word here is just chronic. And so here they're saying that mostly it's the proliferation of more mature white blood cells are the ones that are implicated for this one. So classification according to type of cell and tissue involved. So we have acute myelogenous leukemia, AML, or they may call it acute myeloid leukemia as well. So this one happens in all ages. It's the most common non-lymphocytic leukemia. There is what is known as acute lymphocytic leukemia, ALL. It's the most common in children, and it happens more so in boys than in girls. There's what is known as chronic myelogenous leukemia, CML, or they may call it chronic myeloid leukemia. This one occurs more frequently in adults over 50 and common in people younger than 20. There is what is known as chronic lymphocytic leukemia, CLL, most common form of leukemia apparently, primarily in people over 50. This one affects men more often. At the very least, I would want you to know which one is more prevalent in children, and we've already been told that it's acute lymphocytic leukemia. And then really the one for the older people is CML and CLL, because AML basically happens in everybody. So just want to start kind of thinking about, okay, what am I noticing here that's a little bit different? So for the acute myeloid leukemia, AML, so we're going to just start focusing on what are some of the differences here a little bit. So for this one, it's a defect in the stem cell that has the potential to differentiate into all myeloid cells. So you have monocytes, granulocytes, erythrocytes, and platelets. So defect in the stem cells that can essentially become all of these things over here. So what I want you to focus on is the fact that if that is the potential of what this stem cell can differentiate into, and then this patient has leukemia, what does that mean for you in terms of all of these things, like your monocytes, granulocytes, erythrocytes, and platelets? So obviously they're all going to be impaired in some way, and there's going to be a problem in terms of the amount that you have, whether or not they're healthy, and whether or not they're able to do their job to keep you strong and healthy. So maybe your platelets are going to decrease. So because essentially you'll be getting, if it's a true leukemia, true cancer, there will be a proliferation, yes. But remember what I said, they're not very good. They're not good cells. So you get a lot of them, but then they die off. And remember, platelets are supposed to keep you from bleeding out. So if that's not happening anymore, that's not working, what's going to happen to you? You may bleed out. That's why a lot of patients, depending on how advanced their cancer is, sometimes they get a lot of bleeding tendencies and a lot of bleeding problems. It's considered the most common non-lymphocytic leukemia. It affects all ages with peak incidence at age 60 years. The prognosis is variable. Some of your manifestations include things like fever and infection, weakness and fatigue, bleeding tendencies, which I mentioned, pain from enlarged liver or spleen, hyperplasia of the gums, and things like bone pain. So the treatment, and you're going to see that some of this treatment is the same across the board. So they want to get rid of this cancer as aggressively as they possibly can. So when the patient is on chemotherapy, they'll usually give them a medication, and they'll do it through 3 phases. So they'll do what is known as induction therapy, and then they'll do what is known as consolidation therapy, and what is also known as maintenance therapy. And I'll talk about all of this later on. But under induction, that's when they give you the medication at the very beginning, and they give you the highest dose possible that they can give you. And the goal is they literally want to obliterate all the cancer cells that they can find. And unfortunately, what happens is the patient becomes very, very sick just from the chemotherapy itself. Depending on how bad the situation is, obviously, they can also do things like a bone marrow transplant if that's necessary, or they can do what is known as a PBSCT. So that is a peripheral blood stem cell transplantation, because remember we said that there was a problem in the stem cell. There was a defect in the stem cell. So it's a peripheral blood stem cell transplantation, and what they're doing is they're replacing the blood forming stem cells for more healthier ones. All right. So some signs and symptoms that you can see. So look at all these gums here. They're red. They're inflamed. The teeth don't look so great, right? There are gaps in the teeth. They're yellow. They look like they're about to pop out, quite honestly. Yeah, so just not very good. Some of the leukemic infiltrates that the patient may have. So this is some of your bleeding tendencies you may have. So you may be having even maybe coagulation defects at this point. So all of that is a problem. For the chronic myeloid leukemia, so CML, so for this one specifically, they're telling us that there's a mutation in the myeloid stem cell, and you're getting uncontrolled proliferation of cells. Specifically, they're naming something known as a Philadelphia chromosome. So for the Philadelphia chromosome, the way that this is described, it's basically chromosome 22 is missing a section, or it's missing a piece. So there's a section of DNA that is missing from chromosome 22. So this is one way that they are able to basically identify this particular type of leukemia. There are different stages that can happen under this type of leukemia. So chronic phase, transformational phase, and a blast crisis. I do not need you to worry about these stages so much. This particular type of leukemia is uncommon in people younger than age 20, with increased incidence with age, mean age about 55 to 60, life expectancy 3 to 5 years. All right. So now you're trying to see, okay, which ones of the leukemias are like the better ones or the worst ones, right? So you're paying attention to some of those little things as well. So some of your manifestations, so maybe asymptomatic, you're going to see things like malaise, anorexia, weight loss, confusion or shortness of breath caused by leukostasis. And leukostasis is, here you're going to get an extreme increase in the blast cell count. And remember we said that the blast cell was basically a type of WBC. So an extreme increase in the blast cell count. But unfortunately, remember that nothing is ever good. So they're also dying off. You're getting increases in amount, but they're also dying off. But unfortunately, with that, you're getting a decreased tissue perfusion that happens with that as well. So increase in blast cell count, but you're also getting decreased tissue perfusion as an end result from this. You can see things like enlarged tender spleen or an enlarged liver as well. So treatment, I don't want you to worry about the specific meds once again, unless they have made it on your blueprint. But you're noticing that things like chemotherapy, BMT or PBSCT are being mentioned again, even for this type of leukemia. So what was unique about this one? So mutation in myeloid stem cells with uncontrolled proliferation of cells, and we heard about this weird funky thing known as a Philadelphia chromosome. And also another piece for this one, for the CML, is that basically the proliferation that happens in some patients, it can actually extend out. It can travel out into other cavities of your body. So it can go into your lungs. Sorry, it can go into your long bones, in particular your femur. It can go into your liver. It can go into your spleen. And some patients can end up getting a lot of pain from that as well. So it's just another piece of information here. For the acute lymphocytic leukemia, ALL, so this one, it is specifically an uncontrolled proliferation of immature cells from the lymphoid stem cell. We found out that it's primarily in young children, boys more often than girls. Prognosis apparently is good for children. So children tend to do well if they have this type of leukemia, but the older they get, the prognosis gets worse for them. Some of the manifestations that you're going to see for this type of leukemia include the leukemic cell infiltration is common here. You're going to see things like meningeal involvement in liver, spleen, and bone marrow pain. So some of your treatments, once again, so same thing. So chemotherapy, I'm going to highlight once again BMT or PBSCT. There's this thing known as a monoclonal antibody therapy. So this is a type, the monoclonal antibody therapy. That is a type of immunotherapy that empowers the body's immune system to attack the cancer cells. So they come up with this medication. Basically, they make it up in a lab, and they specifically want it to target any antigens in your body, any foreign substances. So it's going after your cancer cells. And obviously, there's this medication here, imatinib mesylate, if for sure they have a Philadelphia chromosome positive situation that may be going on under this one as well. But once again, you're not worried about meds whatsoever. You're looking at BMT, PBSCT. I would probably want you to know monoclonal antibody therapy as well, just very loosely though. For the chronic lymphocytic leukemia, CLL, so for this one, you're getting what are known as malignant B lymphocytes, most of which are mature. They may escape apoptosis. So apoptosis, apoptosis, oh boy, apoptosis. So this is programmed cell death. So your cells basically are supposed to die off. It's supposed to be a normal and controlled part of an organism's growth and development, that they go through this process. So unfortunately here they're not dying off. So you're getting this excessive accumulation of cells in your body. And obviously if they're supposed to die, that means they've done their duty. So why are they still sticking around, right? So it's a problem if they're still there. So once again, think leukemia, think proliferation, think too much of something going on. Considered most common form of leukemia, more common in older adults, affects men more often. Survival varies for this one anywhere from 2 to 14 years, depending on the stage. Some of the manifestations you're going to be seeing. So things like lymphadenopathy, hepatomegaly, splenomegaly. In later stages, things like anemias and thrombocytopenia. Autoimmune complications with reticular endothelial system destroying the RBCs and your platelets. So your reticular endothelial system has to do with the system that basically protects you from any pathogens that may be in your body. So this is like the macrophage system that eats up any bacteria or any weird funky things. So here, unfortunately, the macrophages that you have will end up destroying your RBCs and platelets. That can happen here. With this one, you're going to be seeing also B symptoms, and the B symptoms include things like fever, sweats, night sweats primarily, and weight loss. So the B symptoms, you're going to see this again when I'm talking about, I think under Hodgkin's, the B symptoms are going to show up again. So I want you to start paying attention to what those are. So early stage may require no treatment. You may just need maybe, early stage may require no treatment. Obviously, later on, you're going to be needing things like chemotherapy and maybe monoclonal antibody therapy, which we described on a previous slide. All right, so lymphadenopathy. So remember with the lymphoid tissue where it's located, I think we saw this under our immunity, and we could see all the different places where we have lymphoid tissue that's basically trying to protect us. So look here under the armpits, how horrible that is, right? Pretty engorged. Your diagnostic tests. So obviously aggressive physical examination always. In acute leukemia, what may you find? So decreased hemoglobin, hematocrit, low platelets, abnormal white blood cell counts, all of that. Key thing though is the WBC count can be low, it can be normal, it can be high. So the WBC count itself is variable. So we do know that in leukemia, there's a proliferation of cells that happens, but then at the same time, some of them end up dying off. So depending on when you're doing all your blood testing, then that amount is going to be different at different times. And across the board, though, the higher your WBC, the poorer your prognosis is. So a high WBC count is consistent with poor prognosis. So some of the other tests, so bone marrow aspiration and biopsy, just to see and look at everything closely. They're looking for surface antigens and markers which help diagnose type of leukemia and the prognosis. I'll talk about more of this under the cancer PowerPoint as well. You're looking at your blood clotting mechanisms, and they're usually abnormal, and your APTT may be prolonged. Some of your clinical manifestations. So you're going to find a lot of this in acute, but you can also find it in chronic. So for your purposes, these are just the general manifestations that you may see. So under cardiovascular system, so things like increased heart rate, decreased BP, murmurs and bruits, increased capillary filling time. Under respiratory, increased respiratory rate, signs and symptoms of pneumonia, cough, shortness of breath, abnormal breath sounds on auscultation. Under the skin and mucous membranes, they're pale, they're cool to touch. The patient is pale, there's petechia there present. Maybe they have bleeding gums, they have sores in the oral cavity. All of that is a possibility. Under the GI, they have increased bleeding tendency, weight loss, nausea, anorexia, decreased bowel sounds, constipation, abdominal tenderness, all of that can happen. If there's maybe even metastases now and the situation is really bad, you may be seeing things like cranial nerve disturbances, headache, papilledema, seizure activity, and coma. Miscellaneous things, bone and joint tenderness, and enlarged lymph nodes or masses. So any of these are things that you might see in a patient who has leukemia. I think for the most part you can understand why all of this is happening. So goal of treatment, so you want to stop the proliferation and infiltration of abnormal and immature leukocytes. If that is what is going on, you want to obtain as long a remission as possible. Leukemia, so even though some of them had a better prognosis than others, it's still considered a most curable form of cancer because there's a lot of research that's being done in this particular area. So I mean, you always want to start, I guess, early in terms of your treatment. You want to diagnose it early, and the sooner you do that, the better. For the phases of drug therapy, so primarily here, so these are the different phases for like specifically chemotherapy for sure. So I want you to know what the goal of each phase is. I want you to know what is it that they're trying to accomplish, for instance, when they're doing induction or when they're doing consolidation or when they're doing maintenance therapy. I need you to have a pretty good idea of all of that. So under induction therapy, so this is where they're giving you an intense dose of chemotherapy. And what they're trying to do here is achieve a rapid or complete remission. And they'll give you this huge dose of chemo, maybe for something like 7 days. They're going to give you some major medications. One example that they may use is something like cytosine, so CYTOSINE. Once again, you're only worried about the meds on your blueprint. But unfortunately, this particular medication, some of the side effects include things like severe bone marrow depression, nausea and vomiting, alopecia, stomatitis, kidney toxicity, right? So some really, really strong meds that they're giving to you under induction therapy, but they're trying to kill off as much of the cancer cells that they can. And the reason why you're losing your hair and you're losing your nails and your GI system is shedding and you're bleeding when they're giving you chemo is because all of those areas have cells that grow very rapidly. And remember, cancer cells proliferate, they grow quickly, they grow fast. So unfortunately, when you're getting chemo, they're targeting any cells that grow rapidly as well. So your hair grows pretty fast, your hair is going to fall out because it's basically just destroying all of those tissues as well. Under consolidation therapy, this is to kill any cancer cells that survived the first stage. So any cancer cells that made it past induction therapy, we're going to go in now. We're going to try to go for those as well. So this induction therapy, they can do this even for as long as 1 to 2 years. It depends on the patient, right? You always want to end up in remission. That is your goal. Like you want to end up having gotten rid of everything and your cancer is in remission. So for them to figure out how long they have to stay in consolidation therapy, it's going to depend on how the patient is reacting to the treatment. So maybe an example medication that they can do under consolidation therapy might be something like even methotrexate, right? So they'll give the patient that medication. But remember, methotrexate, pregnant women can't be getting it. The side effects of methotrexate, from what we've studied before, are not, easy either, right? They're pretty toxic to you. And then there's what is known as maintenance therapy. So under maintenance therapy here, they want to maintain remission. So the idea is that they've killed off the cancer cells, so they've reached remission, and they want to maintain it once it's been achieved. So this can be prescribed for months to years after induction and consolidation. And maybe under maintenance therapy, they can use combination medications or combination anti-neoplastic agents. So maybe they'll use something like vincristine, vincristine, vincristine sulfate. Maybe in addition, they'll give prednisone with that, or maybe they'll give cyclophosphamide, cyclophosphamide. So any different types of combinations of medications may be used for maintenance therapy to kind of keep you in remission. The key thing is, like, what makes the difference between you having consolidation therapy. So once they've done induction therapy, for instance, they're going to monitor you very closely. The patient is going to be incredibly ill in induction therapy, like sick, throwing up, all of that. And then they're going to see how you recover from all of that. They're going to monitor your neutrophil count. They're going to look at your platelet counts. And ideally, they want that to go back to normal. So they're watching it closely. So in consolidation therapy, that's what they're looking for. They're going to be looking to see whether or not, your infections are getting better. And so ideally in consolidation therapy, they're going to decrease the dose of medication. So in induction, high dose, they see how you recover from it, and then they'll give you a lower dose under consolidation therapy because they don't want you to die just from getting all these meds, right? And then hopefully they reach remission, and then in maintenance, they'll see what they need to give you to kind of keep you going. So it's a very tricky, complicated area of medicine. I don't know if any of you are interested in doing working with cancer patients, but it's incredibly challenging, but it's also very rewarding when you see your patients going into remission. So you're also looking at other therapies that they can do. So they can do with chemo, they can do things like radiation therapy. And ideally, when they're adding things like radiation, they're trying to prevent central nervous system from getting affected as well. So when they're trying to use different types of therapies at once, they don't want the cancer to metastasize and move to other areas. So there's CNS prophylaxis as much as possible to make sure that that does not happen, because if the cancer progresses and gets worse, then that's really not going to be a good thing. So whatever it takes to basically prevent this cancer from spreading, they will be doing that. So antibiotics, infection protection, all of that. And we already mentioned the fact that they can do bone marrow transplants if necessary. All right. So your nursing problems. So what does that look like? So risk for infection. So I'm going to fly through these because at this point you should be familiar with all of these as well. So risk for infection, risk for injury, fatigue, impaired skin integrity, altered oral mucous membranes, total self-care deficit. None of this is strange for you guys. At this point, you know what you need to be doing for any of these conditions. The only unique feature right now is that the patient has leukemia and they're probably going to be sicker, right, than maybe a regular patient that has a risk for injury. Like let's say a patient that has risk for injury because they have a fracture, or they have risk for injury because they have I don't know, they can't walk or something like that. But now they have leukemia, so it's a different condition. But in terms of you protecting them, some of the nursing implementation is the same, but it may be a little bit more complex because now you may be dealing with the fact that the patient on top of that now is on neutropenic precautions. So it's just you have to really think about all of that. So depending on whatever your diagnoses were, so what you're going to prevent infections, facilitate breathing, decrease energy requirements, you're going to look at their safety, observe for signs of decreased cerebral perfusion, preventing any hemorrhaging. You're going to look at their diet. Diet becomes extremely important, especially if they're neutropenic, and we'll talk about that. And we've talked about neutropenia already in our slides from before, chapter 33. What does the pain management look like? So this is really tricky. Patients are in pain a lot, right? So, and then sometimes the pain medications they're on makes them nauseous. So it's just a lot that you have to deal with. And then chemotherapy complications, right? And we'll discuss more of this under the other PowerPoint under cancer. So, and what does your patient teaching look like? So symptoms of leukemia. So you're going to think ANT. So anemia, neutropenia, and thrombocytopenia. So immature white blood cells. So you're thinking leukemia is numerous immature white blood cells, like ants in an ant colony. So this is just one way that you can think of this as well. Then you're thinking of anti-cancer, adverse reactions, precautions, all the different things that can happen when they're trying to give you treatment. So getting things like bone marrow suppression, you're getting things like nausea and vomiting, anorexia, you don't want to eat, you're getting GI disturbances, you're getting alopecia, and obviously you want to avoid pregnancy because this is such a stressor on your body, having leukemia, right? So if you know that maybe leukemia runs in your family, and I'm making this up, maybe leukemia runs in your family and you want to have a child, it may not be a bad idea, to have your husband save, not your husband, you save some eggs, but maybe if your husband is the one that has leukemia, obviously, maybe he saves some sperm. You put all of that away for use later on, because if you have leukemia and then you get pregnant, that is not an ideal situation. We've already discussed the fact that some of these medications will actually hurt the baby, so that won't be good. Your assessment, so these are very easy, guys. You can literally just read these and they make sense. So you're looking at your health history, assessing symptoms of leukemia and for complications of anemia, infection, and bleeding, looking for weakness and fatigue. You're looking at your laboratory tests, your leukocyte count, your ANC, and we highlighted ANC already when we were talking about neutropenia in another slide, your hematocrit, platelets, electrolytes, all of that, culture reports, how are they coming back? You're assessing all of this. Some of your diagnoses, we've mentioned some of these already: risk for bleeding, risk for impaired skin integrity, impaired gas exchange, impaired mucous membrane, imbalanced nutrition, acute pain, hyperthermia, because your regulation for temperature may end up not even working properly, especially when the patients become neutropenic, right? Fatigue and activity intolerance, impaired physical mobility, all of this you're looking at closely. Other diagnoses, so risk for excess fluid volume, diarrhea, risk for deficient fluid volume, self-care deficit, anxiety, disturbed body image, grieving diagnoses, potential for spiritual distress. People are going to start asking, why me? Because it's pretty much a death sentence for some people, depending on the type of leukemia you have. Once again, because people can go into remission or they might not. So it's just really, really stressful. Deficient knowledge, all of that. And then on top of it, if they have, maybe they're older and they have some other issues already, so this is where things like risk for excess fluid volume, maybe they have heart issues, maybe they have hypertension. Like, there's just so many things that can go wrong. Your collaborative problems, so infection, bleeding, renal dysfunction, tumor lysis syndrome. We're going to talk about tumor lysis syndrome in the other PowerPoint. Nutritional depletion, mucositis, depression. Depression is a big one. Your planning is going to depend on whatever your nursing diagnoses are. So for mucositis, for instance, so frequent or gentle oral hygiene, keyword being gentle, soft toothbrush, or if your ANC counts are very low, sponge-tipped applicators, rinse only with normal saline and baking soda or prescribed solutions, perineal and rectal care as much as possible, because you don't want them to end up with an infection on top of everything else, right? Improving nutritional intake. So this is where diet is a big deal. So we've mentioned oral care already, before and after meals, giving analgesics before meals, appropriate treatment of nausea, small frequent feedings, soft foods that are moderate in temperature, moderate because sometimes, especially if they have things like mucositis, that's going to burn them. A low microbial diet, so that's also known as a neutropenic diet. So this is literally no foods that has any bacteria, viruses, or yeasts or molds. So for sure, no fresh fruits, no fresh vegetables, no raw undercooked meats, raw cooked fish like sushi. This is not the time to be having sushi. No soft cheese from unpasteurized milk, right? Unpasteurized milk, because it has raw stuff in it, viruses and all this gut bacteria. No, we don't want any of that in there. This is where you want everything kind of dead. This is when you're eating like a well-done cheeseburger that's, like beyond dead, because their patient is just not, their immune system is crazy. And any nutritional supplements as needed. All right, for pain and discomfort, what are you doing? So giving Tylenol for fever and myalgias, cool water, sponging, frequent bedding changes, gentle massage, and relaxation techniques. So any of that, like meditation, guided imagery, relaxing music, whatever you can think of to basically just make your patient feel better. Decreasing fatigue, you're balancing activity and rest. You are maintaining fluid and electrolyte balance, so INOs, daily weights, assessing for dehydration and overload. You're looking at your electrolytes, blood urea, nitrogen, creatinine, and hematocrit to see whether or not they're going into things like renal failure. You're replacing your fluid as needed, and you are definitely paying attention to the how much the patient is able to do for themselves. So you want them to improve in their self-care, their self-esteem, anxiety, and grief with emphatic listening and realistic reassurance. You're basically there for the patient. You are paying attention to them, and you're making sure that all of their needs are met. And I will stop over here. We are not going to do myelodysplastic syndrome, MDS. We're going to skip that. And the next time you hear me, I'll be talking about polycythemia vera.